Okay, imagine this. You've got a teenager, right? Struggling with depression. It's sadly pretty common. We obviously want to help them. But what if treating that depression could also maybe stop something much more severe, like psychosis, from developing later on?
Yeah, that's a really compelling idea. People call it the intervention as prevention hypothesis.
Exactly. And today we're doing a deep dive into this really fascinating recent study out of Finland. Took a hard look at whether giving SSRIs for adolescent depression actually lowers the risk of psychosis later in life.
It's a critical question.
So our mission here is basically to unpack this complex research for you. We'll look at the methods they used, which are pretty ingenious, actually.
hmm
The results, which were, well, maybe a bit surprising, and what it all means for how we think about mental health and, prevention.
Yeah, hopefully give you a shortcut to getting up to speed on this.
Okay, so let's set the stage a bit. Psychotic disorders, things like schizophrenia,
Hmm.
they can be incredibly impactful, right? Often really disabling.
Absolutely. And what researchers have noticed for a long time is that these disorders often don't just appear out of the blue. They're frequently preceded by other mental health issues in youth, especially depression.
Right. I read that studies show maybe up to half of all psychosis cases happened in people who actually saw a child in adolescent mental health services earlier.
That's right. Yeah. And often the reason they were there was for depression.
So it seems logical, doesn't it? This idea that, well, if we treat the depression early, maybe with antidepressants, we could cut the risk of psychosis down the road.
It's a very appealing idea. The thinking goes maybe it improves mood, maybe it changes how people appraise early weird experiences, maybe it affects stress pathways in the brain.
Makes sense on the surface.
But, and this is the fascinating part, actually testing that idea is incredibly difficult with standard research methods.
Why is that? What's the big hurdle?
Well, if you just do an observational study, just watch who gets treatment and what happens, you run into this huge problem. It's called confounding by indication.
Confounding by indication. Okay, break that down.
Sure, think of it like this. People who have more severe depression are naturally more likely to be prescribed SSRIs, right?
Okay, yeah.
But severe depression itself is also known to be linked to a higher risk of developing psychosis later on.
Ah, I see. So if you just observe, it might look like the SSRIs are linked to more psychosis.
Exactly. It might look like they increase the risk, but only because they're being given more often to the kids who are already at higher risk due to the severity of their depression.
It's like noticing umbrellas are mostly used when it's raining and thinking the umbrellas cause the rain.
Precisely. You're seeing an association, but it's not necessarily causal because of that underlying factor, the rain, or in this case, the depression severity.
Okay, so observational studies are tricky. What about the gold standard? Like a randomized controlled trial, an RCT.
Well, that's the other major roadblock. An RCT just isn't really feasible or ethical here.
Why not ethical?
Yeah. Because you'd have to randomly tell some depressed adolescents, okay, you get the standard evidence-based medication, and tell others, nope, you get a placebo or nothing. Even though we know SSRIs can help with depression, you can't ethically withhold treatment like that.
Right. Okay, that makes sense.
And then there's the practical side. Psychosis often doesn't develop until people are, say, in their mid-20s on average. So you'd need to follow these kids for years, maybe a decade or more, after the depression treatment. That makes an RCT incredibly long, expensive, and difficult to manage. People drop out, things change.
Wow. Yeah. Okay, so observational studies have confounding. RCTs are basically impossible. How did these researchers in Finland get around this? This is where it gets interesting,
So
right?
this is where it gets really interesting, yeah. They used a clever approach called a quasi-experimental method. Specifically, something called instrumental variable analysis, or IV analysis.
Instrumental variable.
Yeah.
Okay, sounds technical. What's the basic idea?
The core idea is to find something that influences whether someone gets the treatment, in this case, SSRIs, but isn't directly related to how sick they are or their underlying risk of psychosis.
Like what?
Well, they use the natural variation in prescribing habits between different hospital districts in Finland.
Wait, so doctors in different regions prescribe SSRIs differently, even for similar patients?
Yeah, there's often some variation. Some districts might have guidelines or local practices that lead to slightly higher or lower rates of prescribing SSRIs, just as a general tendency. And crucially, patients are usually assigned to a hospital district based on where they live, not because their depression is more or less severe.
Ah, okay. So where you live influences your chance of getting an SSRI kind of randomly, irrespective of your actual depression severity.
Sort of, yeah. It acts a bit like a natural experiment. The instrument is the prescribing preference of the hospital district you happen to live in. It predicts treatment uptake, but it shouldn't directly predict your psychosis risk except through its effect on treatment.
That is clever. It's like finding a loophole to estimate the causal effect without a real RCT.
Exactly. It allows researchers to get closer to a causal estimate by using this naturally occurring variation as a kind of randomizer, helping to cut through that confounding by indication problem we talked about.
Okay, so they had the SMART method. Tell us about the study itself. Who were they looking at?
This is a massive study. They used linked national registry data for essentially everyone born in Finland between 1987 and 1997.
Wow, the whole birth cohort.
Pretty much, nearly 700,000 people. Using these administrative registries is a huge strength. You get objective data on diagnoses, prescriptions, hospital visits, without relying on people's memory or willingness to participate.
And who did they focus on within that huge group?
They zeroed in on the individuals diagnosed with depression before they turned 18. That came out to 22,666 adolescents.
Okay, a substantial group. And how did they measure the SSRI treatment and the outcome?
Right, so for treatment, they looked at cumulative SSRI use based on medication purchase and reimbursement records. So not just getting a prescription, but actually filling it.
Makes sense.
They looked at this over 1, 2, and 3 years after the initial depression diagnosis, and it turns out a lot of these kids did use SSRIs, about 60%, over 13,000 of them.
60%, okay.
Yeah.
And the outcome they were tracking?
The outcome was a diagnosis of a non-affective psychotic disorder, think things like schizophrenia, by the time the participants were between 20 and 29 years old. So they followed them for a good long time.
And did many develop psychosis?
Sadly, yes.
Mhm.
About 10.7% of those adolescents diagnosed with depression were later diagnosed with a non-affective psychotic disorder. That's quite a high rate.
Wow, yeah. Did they account for other factors like family history or how severe the depression was initially?
Oh, yeah, absolutely. They adjusted for a whole host of things using the registry data, parental education, the person's sex, age at diagnosis, any prior psychiatric history, family history of psychosis or hospitalizations, and even characteristics of the hospital district itself, really trying to isolate the SSRI effect.
Okay, so we have this incredibly robust study design.
Mhm.
Large population, careful measurements, sophisticated analysis. The big question is, what did they find? Did treating depression with SSRIs prevent psychosis?
Well, this is where the results get surprising, especially given how strong that intervention as prevention idea feels. Using their rigorous instrumental variable analysis, they found no evidence to support the hypothesis.
No evidence at all.
Nope. SSRI treatment for adolescent depression did not seem to reduce the subsequent risk of developing a non-affective psychotic disorder.
Wow. So that appealing idea just didn't hold up in this data.
Not according to this analysis, no.
Was this finding consistent? Like maybe it works for shorter treatment or longer?
Remarkably consistent. They looked at 1 year, 2 years, and 3 years of sustained SSRI treatment measured by those reimbursements, suggesting people were actually taking the medication for that long. And the result was the same. No significant reduction in psychosis risk.
Any specific groups where it maybe did work? Or specific SSRIs?
They checked that too. They ran sensitivity analyses looking at different subgroups, males, females, different levels of maternal education, different ages of diagnosis. Still no effect. They even looked at the most common individual SSRIs, fluoxetine, citalopram, sertraline, escitalopram. Same result across the board.
Yeah.
No preventative effect found.
It's pretty definitive then, from this study at least.
Hmm.
What about those simpler analyses you mentioned earlier, the ones without the fancy IV method?
Yes. And this is crucial for understanding why the IV method was so important. When they ran those simpler, more traditional observational analyses, the kind prone to confounding by indication, what did they see?
What?
They actually saw an increased risk of psychosis associated with SSRI use.
Whoa. So the simple look made it seem like SSRIs were harmful.
Exactly, which is almost certainly just that confounding effect we discussed, the sicker kids getting the SSRIs and also being higher risk for psychosis anyway.
So the IV analysis completely flipped that apparent finding.
Precisely. It strongly suggests that the apparent increased risk in the simple analysis was bias, and when you use a method designed to get closer to causality, that association disappears, and importantly, no protective effect emerges either.
That really highlights the difference the method makes.
Okay, so stepping back, what are the bigger implications here? Why does this finding matter beyond just this specific question?
Well, it's a pretty significant challenge to a widely held belief in mental health, this whole intervention as prevention idea, at least in this specific context.
The idea that treating common issues automatically stops severe ones later. Yeah, the assumption that if we just manage, say, depression or anxiety effectively in young people, that will inherently reduce their chances of developing something like schizophrenia or bipolar disorder down the line. This study, focusing on depression, SSRIs, and psychosis, suggests we really can't just assume that. Early symptom treatment might be crucial for the depression itself, but it doesn't automatically translate into preventing a distinct severe mental illness later on.
So it's not saying don't treat adolescent depression.
Absolutely not. Treating depression is incredibly important for the young person's well-being right now. SSRIs are effective for many. The study doesn't change that at all.
But it does question whether that treatment doubles as psychosis prevention.
Exactly. It decouples those two things, suggesting the pathways might be more complex or distinct than we thought.
So if treating the early symptoms isn't the magic bullet for preventing later severe illness, where should we be looking? What does this study suggest for future research or prevention strategies?
I think it calls for two main things. First, more really rigorous, causally focused research on the long-term effects of all sorts of youth mental health interventions. We need more studies like this one that try hard to get past simple correlations.
In Tekken.
Second, it points towards needing perhaps more targeted, precision approaches for preventing severe mental illness. Instead of just treating general symptoms like depression and hoping it prevents psychosis, maybe we need to focus on interventions that more directly target the specific mechanisms we think actually underlie the development of conditions like schizophrenia.
Okay, like what kind of mechanisms or interventions?
Well, the paper suggests a few avenues. From a biological angle, maybe exploring things that affect neuroinflammation or synaptic pruning, how brain connections are refined. So,
Mhm.
testing medications like anti-inflammatories, or maybe drugs that affect the brain's immune system, or even things like GLP-1 agonists, which are used for diabetes but might have neurological effects.
Interesting. What about non-drug approaches?
Absolutely. On the psychosocial side, the paper calls for robust causal assessments of interventions aimed at things we know increase risk for severe mental illness, like interventions to reduce childhood adversity deprivation, maltreatment, also things like parenting interventions or programs promoting social inclusion for vulnerable youth.
So focusing on factors more directly linked to the potential causes of severe mental illness rather than just the early symptoms that might precede it.
Kind of, yeah, or at least rigorously testing if those broader interventions do have a preventative effect on severe outcomes using strong methods.
Just to circle back on the study itself, its strengths were clearly the huge population size, the quasi-experimental design, the objective data.
Yeah, the IV design, testing the assumptions behind it, using that total population cohort, the administrative data, avoiding recall bias, the long follow-up, these are major strengths you just couldn't get easily with an RCT. And while they couldn't know for sure if someone swallowed every pill, focusing on sustained treatment via reimbursements likely captured people with better adherence anyway.
Okay, so let's try and summarize the core takeaway from this deep dive.
I'd say the main point is that while treating adolescent depression is vital for its own sake, this very large, well-designed, finished study using quasi-experimental methods found no evidence that SSRI treatment actually prevents the later onset of psychosis.
It challenges that specific intervention as prevention pathway.
It really does. It underscores how important it is to, question our assumptions, even the really appealing ones, and to keep pushing for research that can really get at cause and effect in mental health. We need to follow the data.
So it leaves us with a pretty big thought, doesn't it? If directly treating symptoms like depression doesn't consistently prevent a distinct severe illness like psychosis later on, what does that tell us about how mental health actually develops? Maybe the pathways are more complicated, less linear than we sometimes assume,
Exactly.
and maybe we need to think more broadly about what true prevention really means in mental health care. What does it encompass beyond just managing current symptoms?
That's the critical question moving forward, I think.